Good morning, all of you. Let's discuss the development of the urinary system. Why should we learn about the development of urinary system? Because congenital anomalies of the kidney and urinary tract occurs in 3 to 6 per thousand live births, account for the most cases of pediatric end-stage renal disease. And also, congenital anomalies of the kidney and urinary tract are responsible for 34 to 59% of chronic kidney disease and for 31% of all cases of end-stage renal failure in children in the United States. Human urinary system has 2 kidneys, 2 ureters and bladder. These are the objectives of this lecture. At the end of the lecture, you should be able to describe the role of the intermediate mesoderm in the development of the urinary system. State the kidney systems in developing embryo and their fate. List the derivatives of the ureteric bud and metanephric mesoderm. And you should know the positional changes of the kidneys during the development stage. And you should know the embryological origin of duplication of ureter, pelvic kidney, horseshoe kidney, S-shaped kidney and the polycystic kidney disease. These are the common congenital anomalies due to some problems of development of the urinary system. Before start the lecture, I have to highlight 3 important things. First one is both kidneys and ureter originated along with the reproductive system such as testes, ovary, seminal vesicles, fallopian tubes and the uterus. Next important thing is the urinary system along with the reproductive system is developed from intermediate mesoderm. And last one is the both systems, that means the reproductive and the urinary systems, start around 4th week of intrauterine life and complete the development around 11 to 12 weeks of intrauterine life. So what is the intermediate mesoderm? Human urinary system is developed from the intermediate mesoderm, and in embryologically the mesodermal cells close to the midline and form thick plate of tissue which is known as paraxial mesoderm, and more laterally the thin layer of mesodermal cells that are called as lateral plate. So the intermediate mesoderm is the mesodermal cells in between paraxial mesoderm and the lateral plate mesoderm. As I told earlier, development of the urinary system begins from 4th week of intrauterine life. In human, there are 3 kidney systems formed in a craniocaudal sequence during the intrauterine life. These are pronephros, mesonephros and mesonephric duct and metanephros. The pronephros are situated at the region of cervical region, mesonephros and the mesonephric duct at upper thoracic and upper lumbar region, metanephros at lumbosacral or pelvic region. Pronephros appears at the beginning of 4th week of gestation at the cervical region, but it is non-functional and rudimentary kidney part, and which disappears completely at the end of 4th week. The mesonephros and mesonephric duct appears early in the 4th week of gestation at the region of upper thoracic and upper lumbar region, and this is a temporary functional kidney, and the by mesonephros and mesonephric duct involves the formation of urogenital ridge that involves the male genital system, but the urogenital ridge is disappeared in female. The metanephros appears around 5th week of gestation at lumbosacral region, and which involves the formation of definitive kidney and functional permanent kidney of human. In this picture you can see the 3 kidney systems that are formed in intrauterine life. At the region of cervical region, the pronephric system, upper thoracic and upper lumbar region, mesonephric duct and mesonephros, and the lowermost part, the pelvic region, metanephros. So let's discuss the development of human definitive kidney. Human definitive kidney has 2 functional components. These are the collecting system and the excretory unit. These 2 functional components are developed from separate embryological components. The ureteric bud is involved to formation of collecting system, and collecting system includes ureter, renal pelvis, major minor calyces, collecting system of the kidneys up to collecting tubules. The excretory unit or excretory part of human definitive kidney is formed by the metanephric blastema or metanephric mesoderm. The excretory unit of the kidney includes Bowman capsule, proximal convoluted tubule, loop of Henle, and distal convoluted tubules. As I told previously, ureteric bud is involved the development of human collecting system of the human kidney. The ureteric bud is an outgrowth from the mesonephric duct, which is more closer to the entrance of cloaca. This ureteric bud grows towards the metanephric tissue and divides into various generations of branches and ultimately produce the ureter, renal pelvis, major minor calyces, and the collecting system of the kidney up to collecting tubules. Here you can see the ureteric bud, which is originated from the mesonephric duct, and this ureteric bud developed towards the metanephric blastema. The ureteric bud is more closer to the cloacal region, and this ureteric bud divides into various generations like this and produce collecting system of human definitive kidney. Excretory system of the kidney is developed from the metanephric blastema or metanephric mesoderm. Each newly formed collecting tubule is covered at the distal end by metanephric tissue cap. So, under the influence of some growth factors, This metanephric tissue cap forms renal vesicles. These renal vesicles then turn and form S-shaped tubules, and these tubules expand and form the Bowman capsule. Capillaries grow into the Bowman capsule and form glomerulus, and distal end of the excretory duct gets connected with collecting tubule and form complete nephron. Now you can see the metanephric blastema involves the formation of excretory system of human definitive kidney. Each newly formed collecting tubules at the distal end of these collecting tubules are covered by the metanephric tissues. These tissues region is called as metanephric tissue caps. Then, under the influence of some growth factors, these metanephric tissue caps form renal vesicles. In this picture, you can see the blue colored ring-like structure. These are the renal vesicles. And these renal vesicles later form the S-shaped tubules. In here you can see in picture B, you can see the S-shaped tubules, and further expanding of these tubules form the Bowman capsule. Some capillaries innervated into the Bowman capsule and form the glomerulus. Later, the distal end of the excretory duct get connected with the collecting tubules and form complete nephron. Interestingly, the nephrons are formed until birth. Approximately 1 million of nephrons in each kidney, and at birth the kidneys are appeared like lobulated and disappeared during the infant period. Human definitive kidney is formed by the metanephros, which is in the region of pelvic area. So initially the kidneys of human are located at the region of pelvis. But as you all know, our kidneys now, the adult kidneys are situated near the region of lumbar vertebrae. So with the development of the kidneys should ascend from the pelvic region to the lumbar region. That is the definitive position of human kidney. So initially human definitive kidney is in the pelvic region. Therefore the blood supply to the kidney is given by the lateral sacral arteries. Later it shifts to more cranial position, that means the lumbar region. Therefore blood supply become changed and supply is given by renal arteries. During the ascent of the kidneys, these kidneys pass through fork-like interval between right and left umbilical arteries. In this picture you can see the ascent of the kidney. Picture B shows the initial kidneys are situated at the region of pelvis, and later picture C shows that the human definitive kidney is situated at the region of lumbar vertebrae. Here you can see the ascent of kidney. Initially, kidneys are situated at the region of pelvis. So, picture A shows the pelvic kidneys in the pelvis, and the blood supply to the kidneys are given by lateral sacral arteries. During the ascent of the kidney, The last picture, picture D, shows that the kidneys are situated near the region of lumbar vertebrae, and the blood supply to the kidneys are given by definitive renal arteries. And also, hilum of the kidneys at first face anteriorly, but with the development, this organ gradually rotates and the hilum comes face more medially. There are so many congenital anomalies that can be happen during the development of kidney. So, due to some problems with the position of the kidneys, there are main three congenital anomalies you should know. The first one is pelvic kidney and accessory renal arteries, transposition of the kidney. Also, some anomalies that can be happen due to change the shape of kidney. S-shaped kidney, pancake or discoid-like kidneys, and horseshoe kidney. This is the pelvic kidney. Pelvic kidneys is happen due to failure to ascent of the kidneys from the pelvic region to lumbar region. Accessory renal arteries are the persistence of embryonic renal vessels formed during the ascent of the kidneys. Pancake kidney happens due to two kidneys fuse and remain in the pelvic region. S-shaped kidney results due to both kidneys develop in the same side and fuse together. Horseshoe kidneys are developed due to lower poles of two kidneys fuse together. And this because of horseshoe kidney, these kidneys are situated and remain in the pelvic region and not ascend to the lumbar region. This process is prevented by inferior mesenteric artery. Next important thing is polycystic kidney disease. Polycystic kidney disease is the development of multiple cysts in both kidneys. There are two types of polycystic kidney disease, the congenital and acquired. Congenital one also known as infant type polycystic kidney disease, and the acquired one is also known as adult type polycystic kidney disease. This polycystic kidney disease is happen due to collecting tubules don't fuse together with the excretory ducts with the development of urinary system, and multiple cysts form in the kidneys. As I told previously, there are two types, and the infant type or congenital type of polycystic kidney disease is autosomal recessive type, and the adult type or acquired type polycystic kidney disease is autosomal dominant inheritance. And this is the common type of polycystic kidney disease than infant type or congenital type of polycystic kidney disease. Now you can see the polycystic kidney because of multiple cysts on the surface of the kidney size become more enlarged, and normal in pathologically the patient can be presented to the ward with large palpable abdominal mass. And also this polycystic kidney disease can associated with various other disease conditions. Let's see the development of ureter, which is very simple, and the ureter is developed from ureteric bud. The importance of developing ureter is the duplication of ureter can be happen during the development period, and the duplication of ureter is the splitting can be completed with two separate ureters and leaving one kidney, and one of them may open into abnormal sites such as urethra, vagina, vestibule. Now you can see the duplication of ureter, and one part of the ureter can be opened into various sites of the urinary system, and it can be opened into a part of reproductive system also. Because of ureteric bud anomalies, there are more kidneys, like more than two kidneys can be produced due to ureteric bud anomalies. Renal agenesis is a condition of loss of one kidney, which is due to lack of induction of metanephros by ureteric bud. The excretion of urine is done by two kidneys. Because of lack of one kidney, excretory function becomes interrupted and leads to reduced amount of the amniotic fluid. If a pregnant mother comes to the ward with reduced amniotic fluid or oligohydramnios, we should think about this as well. Renal agenesis is a condition due to lack of induction of metanephros by ureteric bud. Because of renal agenesis, reduced amniotic fluid can happen and leads to oligohydramnios. Definitive kidney of human is formed from the metanephros. These are become functional around 12 weeks of gestation, and urine passed into the amniotic cavity and mixed with amniotic cavity later. Let's discuss about the development of bladder and urethra. At the end of the lecture, you should be able to describe the formation of urinary bladder and the urethra, and also the embryological origin of trigone of the bladder, and state the fate of urachus, and briefly explain the developmental origin of urachal fistula, urachal cyst, urachal sinus, and exstrophy of bladder. During the development, the cloaca is divided into two canals, the urogenital sinus, which is the anterior part, and the anal canal, which is in the posterior part. The mesonephric duct and allantois open into the urogenital sinus, and there are three distinct parts we can identify in the urogenital sinus. This urogenital sinus upper part, and which is the largest part, middle part is called as pelvic part, and the lowermost part is called as phallic part. The upper end of the urogenital sinus is involved for the formation of bladder, and the middle part or pelvic part of urogenital sinus is involved to formation of prostatic and membranous part of the urethra in male, and the phallic part which is the lowermost part of the urogenital sinus, is involved to formation of rest of the urethra. Here you can see the cloaca divides into two canals, and the anterior part of that is called as urogenital sinus, and posteriorly anal canal. The urogenital sinus at the upper part which is connected with the communicate with the allantois. Here you can see the cloaca divides into two separate canals, urogenital sinus anteriorly and the anorectal canal posteriorly. In between these two ducts there is a cell cluster which is called as perineal body. The urogenital sinus has three main distinct parts. The upper part of urogenital sinus is involved formation of bladder, and that part is connected with the urachus. And the middle part or the pelvic part of the urogenital sinus is involved formation of prostatic urethra and the membranous urethra of males. And the lowermost part or the phallic part of urogenital sinus is involved for the formation of urethra. Allantois is the lumen become obliterated and forms urachus. The remains connect at the apex of the bladder with umbilicus. In adult life, this allantois become urachus, and urachus forms the median umbilical ligament. Let's discuss the formation of trigone of the bladder. The mesonephric ducts get incorporated into the expanding bladder wall, and with the ascent of the kidneys, ureteric orifices move cranially, and the mesonephric ducts move close together, forming a mesoderm-lined triangular area in bladder wall, which is known as trigone. Later, the mesodermal lining is replaced by endodermal epithelium of the rest of the bladder. Here you can see the mesonephric ducts get incorporated into the expanding bladder wall, and due to ascent of the kidneys, ureteric orifices also move cranially, and mesonephric ducts move close together, forming the region or area which is called as trigone. This is one of the important clinical part of the development of bladder. This condition is known as extrophy of bladder. This is ventral body wall defect, and bladder mucosa is exposed to the outside. Sometimes external genitalia also can involve. Urachal defects also can happen with the development of kidney. Because of partial or complete persistence of intraembryonic part of the allantois, the urachal anomalies can result. The urachal cyst is the condition which have some cyst, multiple or single cyst in the during the course of urachus, and the urachal sinus is the condition due to partially persistent allantois. And the urachal fistula results due to complete persistence of the allantois. Therefore, if in the urachal fistula, the urine can extravasate through the umbilical region. These are my references. Thank you for listening. This is a video link of the development of urinary system. If you have a time, you can watch this and get more understanding about the development of urinary system. Thank you.